First of all, welcome back. Thank you again for coming. We had a pretty amazing day yesterday. Some people have compared it to, with all the experts sort of drinking water from a fire hose. There was just so much. It was just amazing. And so, but I know all of you can take it in. I know you can do that. And so this panel, this plenary this morning is really an exciting one. And I'm not aware that physicians have actually had much chance to talk about how they believe electronic health systems are going to affect their relationships with patients. And so there's many aspects to that, and I want to get out of the way so that you have as much time as possible. So let me introduce the moderator for this session, Michael Stearns. He's the president and CEO, yes, of e-MDs, smaller, I don't know what size. Huge. A huge electronic health record company based in Austin, Texas, it happens. And one of the things that's amazing about e-MDs that we really care about is it was built by family practice doctors primarily. And one of the things that they built in from the beginning, long before anyone thought of bringing this up at the federal level for legislation, is they built in segmentation. So they felt it was important for some information, sensitive information that they hear, they don't hear as much as psychiatrists and psychoanalysts, but they do hear it, did not need to be passed on. And so they built in ways that data could be segmented. And so, Michael?
Thank you very much, Deborah. It's been a great conference so far. Those of you that could make the reception last night, it was very impressive, the speakers and what we heard about privacy and Deborah's efforts, and many of you out there as well. What I'm going to do is get started right away with the panel members. We have a fairly, 5 panel members. Each one has a lot to say. This could probably be a 4-hour session easily once we get going, so hopefully it's going to be very heated, and we're going to have some vigorous debate because doctors sometimes feel that they own the data. And in some countries like Germany, apparently they do, or their notes are copyrighted. But we want to go ahead and we'll start with introductions, and we'll just start right down the line. Fausto? Yes,
hi, good morning. Fausto Meza. I'm actually the Chief Medical Information Officer for a 500-plus bed hospital down in South Texas. I'm a practicing physician. I'm a geriatrician, but I practice as a hospitalist at our hospital.
Thank you.
Good morning. I'm Andy Litt. I'm the Chief Medical Officer for Dell Healthcare and Life Sciences. I'm a neuroradiologist by training. Spent my entire career at NYU before coming to Dell. And Dell has a broad range of services and hardware, obviously, and solutions in healthcare. So this is an important area for us.
Good morning. I'm Wesley Clark. I'm a psychiatrist, and I'm the director of the Center for Behavioral Health Statistics and Quality at the Substance Abuse Mental Services Administration. And prior to that, I was a practicing psychiatrist and addiction medicine specialist at the VA in San Francisco, and interested in both mental health and in general and substance abuse treatment in particular.
Good morning. Michael Weiner. I am the Director of Clinical Informatics for the Veterans Administration Department of Defense Interagency Program Office, in which those 2 agencies are getting together to create a new electronic health record platform. I'm an internist.
Good morning. My name is Scott Monteith. I'm a psychiatrist, practicing psychiatrist, and health information technology consultant, particularly as it relates to matters having to do with risk.
Is there a reason that I was put in between 2 psychiatrists?
We've been meaning to tell you.
I feel like this is all of a sudden become an intervention.
I'm a neurologist. That may balance it a little bit. We share the same board, so I guess we're outnumbered. What we're going to do now is we have some prepared questions, and we want to leave some time at the end for open to the audience to ask questions. We're going to start with Dr. Monteith as the first question, and the other panel members can join in, but we'll give Dr. Monteith the opportunity to respond first. Do you feel that health information technology affects the willingness of patients to share sensitive information with providers?
Yes, absolutely. Health information technology, HIT, definitely affects the willingness to share sensitive information. There are, of course, a variety of HIT-related dynamics that affect the doctor-patient relationship, including trust in our system's ability to maintain privacy, data integrity, the influence of the computer and its presence in the office, and implications for the interaction between the doctor and the patient and others. I'll give two examples of where health information technology has affected patients' willingness to share information in my practice. For context, as I mentioned, I'm a psychiatrist. I practice in a 6-county community mental health setting where we use an EHR that is popular in the behavioral health market. Our patients know that we use computers in our practice, including an EHR. Recently, I had a patient tell me during an initial psychiatric evaluation that she was unwilling to reveal her medical history because she understood that I would be putting the information into the computer. The patient was not psychotic, actually very high functioning. I discussed her concerns and explained my professional and legal responsibilities to maintain privacy and confidentiality. She said that she felt that she had been stigmatized as a result of her diagnoses in the past, and once the information, quote, gets in there, end quote, referring to the computer, she was concerned that there was a good chance that it would ultimately compromise her privacy with possibly damaging effects. She opted not to reveal her private medical information in this regard. In the second example, a patient brought to her treatment team's attention, and I was a member of that team, an error in her EHR-generated record. She stated that she was involved in a child custody battle with her ex-husband, who alleged that she was unfit to be a parent due to a history of substance abuse. Assuming that her medical record would substantiate her claim that she did not have a history of substance abuse, she requested a copy of her record. To her amazement, she found that her record indicated that she had a history of inhalant abuse. She was understandably upset and frustrated, insisting that she had no history of substance abuse. In fact, her report of no substance abuse was consistent with the treatment teams and my assessment. That is, we had not identified any history of a substance abuse disorder per se. I apologize. I looked into the matter, and we found that in a portion of the record that was not normally available to the treatment team, but was available to the patient. She was indeed noted to have a history of inhalant abuse, which, for those of you who may not know, is a particularly destructive form of substance abuse. Not knowing where this diagnosis came from, it did not come from my notes, which are supposed to be the source of our system's official diagnoses. I investigated the matter further. I discovered that our EHR had incorrectly inserted the inhalant abuse diagnosis. It turns out that the EHR did not differentiate between 4 diagnoses that share a common DSM code. DSM is our diagnostic manual in psychiatry. Specifically, there's a numeric code 305.9 in DSM, which covers 4 different diagnoses, ranging from caffeine intoxication to inhalant abuse. The other 2 diagnoses are other / or unknown substance abuse and PCP or angel dust. These are separate and distinct diagnoses which are not supposed to be lumped together clinically. In this patient's case, she did indeed have a history of caffeine intoxication, and this was in my progress notes. This diagnosis means that she basically had a cluster of anxiety-like symptoms stemming from caffeine use, probably not unlike what many of us will be feeling as we drink coffee throughout the day. But there's more. Not only did our EHR bundle 4 different diagnoses into one, but the window for presenting the diagnosis on paper or on a computer screen was only large enough for one of the 4 diagnoses to be seen. And which one was it? It was inhalant abuse. Of course, I profusely apologized to the patient for the EHR's mistake, offered to do whatever we could to set the record straight, including writing a lengthy letter clarifying her diagnoses, explaining that I saw no evidence of substance abuse per se, including no inhalant abuse. The patient was polite, accepted our efforts to set the record straight, but stopped coming to our community mental health. Meanwhile, I dutifully and immediately reported the EHR problem to relevant authorities, including the vendor. All of this occurred about 2 years ago. The problem persists. It's not been fixed. I could go on with more stories, but I just want to end with this. As we know, trust is foundational to most significant human relationships, and honoring privacy is obviously foundational to trust. Whether you're a journalist, investment advisor, business associated, trusted colleague, parent, teacher, researcher, CIA operative, whatever, ask yourself if you could have a successful, significant relationship without trust. Trust and privacy are connected at the hip. The modern version of the Hippocratic Oath, of course, reflects this understanding when it says, "I will respect the privacy of my patients, for their problems are not disclosed to me that the world may know." Finally, the ONC HHS Guide to Security and Privacy says something that I think is very significant. Ensuring privacy and security of health information, including information in the EHR, is a key component to building trust, required to realize the potential benefits of electronic health information. If individuals and other participants in a network lack trust in electronic exchange of information due to, and I emphasize this, perceived or actual risks to electronic health information or the accuracy or completeness of such information, it may affect their willingness to disclose necessary health information and could have life-threatening consequences. That's from the ONC, and I've just given you 2 examples that highlight that exactly. It definitely affects the relationship. As Jim Pyle said yesterday, privacy isn't just a trite notion. It's our ethical and legal obligation. It's important because it's pragmatic. It works. It's essential to healthy human relationships.
Thank you very much. Anyone else care to comment about whether or not HIT prevents patients, inhibits patients from disclosing sensitive information? Anybody else have any comments?
I mean, I'll comment on in the VA and the DoD. There are many diagnoses that I think service members and veterans have been potentially reticent to come forward with because of the fact that we have large global health records that are not just of a local nature in a doctor's office, but once that data is put forward and available under the right circumstances, we call it behind the glass for some of the mental health data, but available if needed. So though we have delivered, I think, a high level of trust to our patient population, implied trust even, I believe that that concern for some of those diagnoses still remains a concern.
The Health Information Technology Strategic Initiative Lead for Substance Abuse and Mental Services Administration, and this issue of trust is foundational to both substance abuse and mental health. As was pointed out, there are examples as we survey the landscape of people misinterpreting data, and as a result, patients have been actually denied care because the information conveyed has been misinterpreted, even though accurate. One woman had a history of violence 10 years earlier. She was a patient in the mental health system. Primary care doctor misinterpreted something that happened 10 years ago as being current, and as a result of that, refused to see her. The meta message to patients is that you are responsible for your own health care and that you cannot rely on the healthcare delivery system to take care of you. So if we lose that trust factor in the physician-patient relationship or clinician-patient relationship or health system-patient relationship, then we have individuals who don't want to comply with our recommendations. They second-guess our recommendations. The other thing that we need to keep in mind, particularly in an electronic era, is that the internet also serves as an alternative source of medical information, however questionable at times. Nevertheless, if people don't trust us, then they will seek refuge to other sources of information, do their own diagnosis, take care of them their own selves, and sometimes they'll do okay and sometimes they won't.
Thank you very much.
I guess I think that the question here is a question around patient trust, and that's really the issue. Patients were reluctant to provide information before the age of electronic medical records, and it's no doubt that that probably makes it worse. The question is, how do we deal with that? And how do we inform the patients, both how do we improve the systems along the lines that was mentioned before in terms of making sure that there are not inaccuracies in the system, although there will always be some inaccuracies in a medical record. There were inaccuracies in the paper medical record, and there will be inaccuracies in the electronic medical record. The issue is how do we work to make sure that that's as minimized as possible, and in fact to use the technology. This is kind of the discussion I think that Dr. Mastashari talked about yesterday, about designing in the system the protections so that these things don't happen, which actually maybe we can do better in the electronic age. But how do we then inform the patients of exactly what's happening to their data, what the restrictions are, and what the current legal and privacy rules are, so that we do build that level of trust? I think that's the issue. I mean, we want, in the end, it seems to me this is not a question, or it shouldn't be a question about do we have electronic records or not. The question is, how do we build patient trust?
Okay, good. We'll go on to the next question. It's for Dr. Clark. There's been a great deal of discussion surrounding whether or not that patients should be able to determine what components of their medical history are shared and who will see this information, in particular for mental health conditions. This process has been referred to as segmentation. What are the benefits and potential challenges related to segmentation?
Well, again, as Scott pointed out, this whole discussion turns on the physician or clinician-patient relationship, and that trust is an inextricable part of that. We, in the substance abuse arena, have been dealing with the issue of consent, which is an integral part of segmentation. And 42 CFR Part 2 and 38 for the VA, 38 CFR Part 1, patient consent is the cornerstone of the transaction. Now, while there are some break-the-glass options available, by and large, the rules require the patient consent to the disclosure of information to whichever party they want. And so the purpose of 42 CFR Part 2 and 38 CFR Part 1 is to encourage people to seek substance abuse treatment without fear that by doing so their privacy will be compromised. And to say that, and that concept is much broader than substance abuse. We should be asking the purpose of the ability to influence what's going on in your record should be to encourage people to seek the medical treatment, not postpone, not delay. We talk about the benefits of early intervention. We talk about heading things off before they develop into more complex issues. If I fear that my privacy will be compromised, I wait until, well, maybe it'll go away, maybe it won't, maybe it'll go away, maybe it won't. And by the time I realize that it won't go away, then I don't really care, but then you're going to spend a lot of money not doing very much for me. So we know that the idea is to give patient consent. And a lot of people say, well, we don't want to be bothered with that, i.e., when we want to treat the chart and not the patient. And we want to be able to do that with alacrity and dispatch. We don't want to be troubled by having to consult the patient. The ability for the patient to segment the information has its benefits, of course. Information included in an electronic database can include a wide range of issues. Scott pointed out that in a child custody case, reference to substance abuse and mistaken reference turned out to be a problem. And the system was still incapable of correcting that, which is another thing that we need to keep in mind. It isn't just having an electronic health record. It is that patients should be able to correct errors, and segmentation will allow the patient to hold back information if and when the patient deems it's appropriate. And so there are such issues as divorce, child custody, criminal justice issues, employer issues, or insurance issues are not complicated by using the patient's medical records. So the question of segmentation and patient control is therefore not limited to substance abuse. It's a much broader issue than that. Some jobs may say, well, gee, if you've got diabetes, I don't want to deal with you. You've got hypertension, I don't want to deal with you. So we recognize the challenge as to how to segment data according to the patient's wishes is an issue. So the real question is, what is the focus? Are we more concerned about the patient's perception of their own well-being, or more concerned about the health system's perception of the patient, i.e., is it too much of a problem to segment the data? Therefore, we don't want to really do that because our existing technology needs to be pushed, and I'm still selling legacy systems. We're selling last year's software, and I don't want to deal with the fact that I need to modernize my efforts. I think the answer is that patient's well-being is the most important thing, and therefore the patient must be able to control what he or she wishes to disclose. And I always like to remind my audiences that this isn't about some remote patient. All of you will wind up seeing a physician or a clinician or a nurse practitioner or somebody. Very few of us escape seeing somebody in the healthcare delivery system. So your question should be, what do you want done with your medical records? Do you want it on the 6 o'clock news? Do you want it on the blog? Do you want some insurance company suddenly showing up selling you stuff knowing that you have XYZ condition? And you say, well, how did they know that? So we want to know who determines what segmented information is needed by a particular provider to offer the best possible care to the patient, and who gets that information. If the patient comes in for a medical problem that they deem not disclosable, then the issue of data segmentation becomes very important. The benefits of allowing an individual to control who has access to their record is offset by always the question of harm. So we want to make sure that there's a participatory decision-making process. You can do electronic redactation of information where the patient's request that information not be shared to a particular entity. It eliminates the need for the receiver to know that there could be a privacy-protected information included in the data exchange. Or you can meta tag each piece of data being shared with the patient's privacy directives. And this approach requires that all parties to the data exchange are able to parse the information and honor the patient's privacy directives for each data element to be in the exchange. This is a more complicated approach. It requires more application intelligence to tag the data as well as to interpret the tags on the receiver's part. But it also requires a commitment on the part of the larger system to value privacy as opposed to the expediency of, look, I can exchange this information as long as there are no, quote, perceived barriers in the exchange of the information. But we need to keep in mind, as Scott pointed out, and this was pointed out by my earlier comments, that the purpose of this is not to foster the development of technology. It's to foster the enhancement of care and the exchange of care. That this is about you as potential patients, if you're not a patient, as well as the people that we treat, because even though we're physicians, we also wind up showing up to another physician for our care, and we need to be able to make the decision. Some people say, well, suppose a person doesn't want to disclose that information. It's, well, then that's their prerogative. It is the practitioner's responsibility to explain things to people. Most people don't want to commit suicide in a doctor's office. So what they want is the doctor to explain to them why that such information needs to be disclosed. And data segmentation then will allow that to occur. This information does not need to go to my employer, to my husband or wife's lawyer, to the criminal justice system, to somebody who wants to sell me the latest, greatest equipment that they want to market. So then the issue is, are we willing to pursue that? And I think ONC is committed to developing the technology in the later phases of meaningful use. That technology is evolving and is available, and we need to invest in it.
Thanks. Just wanted to jump into one of the controversial areas of segmentation, patient safety issues and medical legal aspects of segmentation. Does anybody want to comment on that as well?
I mean, clearly, in terms of patient safety issues, one of the issues is, do we, in addition to a psychiatrist, I'm also a lawyer, and I just happen to be a member of the D.C. Bar. So the issue is the patient shares what information they want to share. The patient assumes some of the responsibility to disclose critical information. The practitioner needs to be able to explain and document that these are the consequences of not sharing certain types of information. You're going to be on multiple medications. I need to know, well, if you're on other medications, I need to know if you've got other conditions. Another practitioner approaches and says, well, I need this information in order to provide care. In emergency situations, even 42 CFR Part 2 allows break-the-glass kind of situations. Now, it precludes redisclosure, but it says for the management of that emergency, even if the patient doesn't want that particular provider to have the information, for the management of that emergency, that information can flow. But the purpose of the flowing of the information is only for the management of that emergency. So, I mean, as any physician knows, you can never escape liability, as it were, in terms of people can sue you for breathing. That's not the point. The point is, would a jury find a practitioner's concern about the welfare of his or her patient so important that they felt that that information had to be disclosed for the care? And was that disclosure reasonable under the circumstances? And if that is the case, then liability is not going to ensue unless this is a nominal thing. On the other hand, if the patient says, I told you, I didn't want this information disclosed, and even though it might kill me, I still don't want that information disclosed, the practitioner is obligated to respect the patient's privacy. The real question is, why did this patient show up in that doctor's office? It's not, as the Hippocratic Oath pointed out, it is not to broadcast their concerns to the world. Whatever those problems are, that has to be negotiated, and by and large, you need to be aware of that. And so medical emergencies are generally covered under the law, even under these privacy considerations. We can deal with that. Data segmentation is something that would be, if you are dealing with version 3.0 and you got version 2.0, then from a legal point of view, why didn't you upgrade? And so if you're dealing with a vendor who's got version 2.0 but not version 3.0, or a vendor who cannot segment and another vendor who can, that creates a conundrum. So we also need this information. If you took the incentives to acquire software from a legal point of view, one would argue that you're not only obligated to take, if you take the incentives, you're obligated to get the most contemporary software now. When does a software capability degrade from a medical legal point of view? I can't say. But you are responsible for making sure that the software that you acquire or the instruments that you use are as contemporary as possible.
Great. All right, thank you very much. Anyone else have any thoughts along those lines?
In the spirit of risk management and liability, I would just add that electronic health records, HIT, present a whole slew of problems. In many respects, and it's been said throughout this conference, we have the tail wagging the dog rather than the dog wagging the tail. HIT's become the new patient. It's driven how we end up practicing a lot of our care. We've traded, a lot of people talk about the issue of legibility. Unfortunately, we've traded illegible writing for legible gibberish, which is often very difficult to interpret. And I think that HIT can serve to perhaps manage some risk management issues, but it creates a tremendous number as well.
Great, thanks. One of the things that's come up amongst our providers is I have 7 minutes to see a patient. I don't have time to explain to them the ramifications of segmentation downstream. So has anyone noticed that, has anyone seen that as an issue, where you just don't have enough time to explain all the consequences of segmenting certain elements of your record? And also, how do you take everything out? Patient has multiple sclerosis. How do you remove everything in the record that will identify them as having that disease? Radiology reports, consultative reports, et cetera. So.
Well, I mean, part of that, what he mentioned, is that level of sophistication. I think that level of sophistication, we really haven't gotten there. We're at the very beginning of evolution of electronic medical records, HIE systems, whether one's compatible with the other. That's just happening now. So being able to exchange information from one system into another system, and them speaking, even though they have appropriate language, we're at such an early evolution of being able to to take some of that, even parse out some of that information, much less exchange it between two different vendors at this point. So that's something that possibly we can't do at this point. That's something I'm going to actually speak about a little bit later is the time. With electronic medical records, anything electronic that you put in front of a physician, they're going to say, this is getting between me and my patient. So definitely, as far as the amount of time that we have for patients, I work in an underserved community. A lot of communities, whether they're rural or urban, there's not enough physicians. We're just trying our best to see enough patients, and on top of that, handle a lot of these other issues. In the end, though, sometimes our staff, whether at the front office or whether in a large hospital, there's another provider that's explaining these things. But ultimately, we talked about trust and the relationship with our patient. It falls on us to learn about these things, and it falls on us to do our due diligence, to sit down with the patient and explain to them. So it's going to be a fine balancing act that we're going to be trying to do that.
Great. All right. Thank you very much. We'll go on to the next question. Dr. Litt. Excuse me, health information exchange is felt to be essential if efforts tied to use of health information technology to improve the quality of care provided to patients are to be successful. Can you comment on how well personal health information and health information exchanges is protected?
Yeah, so actually, just to take your question, I think health information exchange, sort of small h, small I, small e, is really important to the care of patients. One of the things that we're finding out more and more is that we don't coordinate care among physicians, among providers, among different hospitals around a single patient. And that's part of the problem, part of the reason why we don't have the quality of care that we would like in this country today. So I think let's start with that as a given, is that we need to have care information more broadly around the patient. I had the opportunity yesterday to be with Leon Rodriguez, who runs the Office of Civil Rights in the Health and Human Services Department. And it was an interesting conversation because he was talking about breaches. He was talking about, exposures of patient information that were not intended, and they're the department, as Dr. Mashashari mentioned yesterday, within HHS that's responsible for managing these breaches and assessing fines and all this kind of stuff. And actually, interestingly, some of the largest breaches have actually been on paper. So there was the Rite Aid case where somebody dumped 5,000 medical records in a dumpster, and then somebody went through the dumpster and pulled out all the records. So, but that's on the one side. On the IT side, what was really interesting was the percentage of cases of breaches that broke out in different sections. So 50% of the breaches happened because of a theft of a device, either a laptop or somebody walked in to steal a server or something of that sort, not because they were looking for medical records, just because, hey, that's a nice new shiny laptop and I don't have one and I'd like that one. Or, somebody, the classic story of the person from Mass General who left their laptop on the T in Boston, right? Now that had nothing to do with medical records, but it exposed medical records, and that's the problem. Interestingly, only 7% of the breaches actually came because of hacking, because of somebody actually trying to go in and get medical records, which I thought was an interesting statistic. So there's a lot around the technology that we need to do to protect patient records, and it's actually there, and we can do it. We just have, as was just said, we just have to enforce it, and we have to enforce the rules. So in terms of HIEs, though, I'm going to propose something that I think some of you may find counterintuitive, but I'll explain it, which is that I think part of the issue is if all of if a lot of the risk, 50% of the risk, is because data is being stored on local devices, my laptop, or a server in a closet in some physician's office that gets broken into, because people are looking for whatever else is in the physician's office, drugs or whatever. Maybe the answer is to get the data out of those environments and to put the data in the cloud, meaning to put the data in data centers that are manned and secured by high-level security organizations that know how to do this and that are HIPAA compliant and that are enforcing all of the privacy standards that we would like. Because once the data is secured in that way, you then end up with actually a reduction in the risk than you would otherwise. And that's actually, there have been no breaches around a health information exchange. In other words, no one has found any evidence that people have been able to suck data out of the wires of the internet as it passed by. They only get it in the endpoints where the data is, quote unquote, at rest, not where the data is in motion. So if you took the data and you moved it to a more secure environment, that would help. Now, if you think about it, in most doctors' offices, I'm going to be a little bit pejorative here, but I think my colleagues won't necessarily disagree with me. Unless you're in a large institution, if it's a 1 or 2 man doctor practice, who do you think the IT guy is? Right? Maybe it's your son, because he's really good with computers. Or maybe it's your brother-in-law, because he doesn't have a job and you kind of gave him a job, or whatever, right? Now, what level of security information and security training and security experience does your son have? I mean, he may be a really smart kid, but I would argue that he's really not a security expert. And he's the one who's responsible for securing your data, your patient data as a physician, right? So that's probably not a good thing. The other thing I will tell you is that when I've talked to, Dell has a large division called SecureWorks that actually does this securing data in hospitals, in financial institutions, across the board, and does what's called intrusion protection, so to stop hackers and other people from coming in. And when they looked at some data and they looked at the criminal element of the hacking population, if you will, the people who do this for a living because they want to steal records, whether it's financial records or otherwise, the place that these guys beta test their malware or whatever is in hospitals, because hospitals are so badly protected, okay, as a rule. So the answer is we can fix that by moving the data out of all these badly protected places into places that are like Fort Knox, and then just have data available and visualized for the clinician and have it non-resident, meaning it doesn't stay on the screen or in the computer where the doctor looks at it. And I think that's probably the best answer, in terms of making sure that these HIEs and other data sources are better protected.
Great. I'm in the interest of time. I think we'll move on to the next question. I think it's actually one, and we'll come back to comments on this question at the end if we have time. Next question is for Dr. Weiner. Can you comment on the subject of data ownership? Should it be the patient, the provider, the HIT vendor, the military, or another entity? And this is a hot topic. This is the one where the Hatfields and McCoys come out, because the patients get very animated and the doctors get very animated, and others are trying to make a profit off it. So it's a kind of a hot topic right now. So please.
I saw this question. I was like, they hate me. I don't know why they hate me. Let me just start with a little bit of history, because I think the history is the fun part on this. First, I will confirm everyone's worst fears of the military. Deb right now is like, yep, I knew it. So 30 years ago, you came in, you lined up with 100 of your closest recruiting friends. They stripped you down, gave you immunizations, recorded everything in a group, and you were sent out sort of with pure lack of privacy for the rest of your career in the military. Every time you were seen for something, that was reported up to your commanding officer, regardless of what it was. And every time you were admitted to the hospital, your commanding officer, and I remember being a junior lieutenant, and then my commanding officer came over to me. He's like, "Doc, what's going on with Jones?" I'm like, "Well, sir," he's like, "Get me the record." So he at the time was able to take the record, flip through it, and see what's going on with his members. And that all just seemed very logical at the time, right? Because we're the military. So I now want to, there was a small little thing in the late 90s called HIPAA. We embraced it fully. Please write that part down. We embraced it fully in 2003. Assistant Secretary of Defense for Health Affairs, Dr. Winkenwerder, who some of you may know. He's still here in town doing good work. Signed off and said, the Department of Defense is fully HIPAA compliant. And I will tell you, working on the commercial side and moonlighting and working also in the military, that the privacy, if anything on the military side now, is cybersecurity almost at its best. Now, we can't prevent stupidity. If you're going to bring home backup tapes and put them in your car and go do something. I mean, these sort of things, right? We're all challenged by this. But 150,000 times a day, outpatients are documented in the Department of Defense. Those patients, all of that data is then stored in one location in Montgomery, Alabama, behind barbed wire fences. There's a moat. There's, the music is playing, so you can't listen. It's one of those facilities that was referred to by my colleague, and it sits tightly behind the Department of Defense network. So I just want to sort of let you know where we are. When it moves as encrypted data, so you can't tap into the wire and pull it down. So that's our current state of affair. I don't know if we have a much better time with system change requests, but 5 years, I think even we've broken that. You may want to look at your vendor.
Agreed.
Now, I want to answer the question. Who owns the data? So now back to the Department of Defense. In the Department of Defense, I believe the Department of Defense would tell you that they own the data for that patient. And there is an implied and a stated privacy built into it. And years ago, to all our patients, we sent out sort of what they were entitled to, and that was no data would ever be released, would it be shared, or anything else without their consent. And I believe we've remained true to that. It's very hard to de-identify our data, so we've, much to the frustration of many of our research colleagues, because we're sitting on somewhere in the neighborhood of 70 terabytes of non-image data for 9.8 million beneficiaries. So it is rich data once we figure out, I think, how to completely de-identify it and can ensure privacy to our patient population. We'll be able to really leverage that. So that's the Department of Defense statement for the morning. Now, Michael Weiner's personal thought. I believe Clay Christensen nailed it, and that is the data needs to go with the patient. So we are moving towards that. We're moving one of our current divisions in our office is for patient and user experience. Right? So an empowered patient we believe in, we buy in. The patient has not been in the center of this conversation, and we have an opportunity to place he or she into the middle of that. So we've done a few small trials of moving the data into personal health records. The patient literally had to come into the hospital with their military ID, confirm, and then they were given access into it. And then once the data is moved to the patient, and an empowered patient, they are then free to do what they want with that data, and they can move it through the system with them. So I think that's where we are headed. We are certainly committed to the nationwide health information network, and how best, the connection for us, the connection from the Department of Defense to that network is a challenge, because we look at that as a security potential threat. I think over the next 5 years, we will see the Department of Defense and the VA patient information available to the patient as they would like it. Right? So I go to my parents and they want nothing to do with their health information at all. But I look at my niece and nephews, and every time they have a cough or a sneeze, they're posting that, and I think they will become more comfortable with owning that data and really demand owning that data. So I think we in the Department of Defense are really a leading indicator. You can capture that. We're a leading indicator of where I think the rest of the nation will be moving to.
Thank you very much. We're nearly out of time. I want to give Dr. Meza a chance to address his question. We sort of touched on it earlier. Some providers have raised concerns about the impact of on their workflow when they're required to explain to patients the nuances and potential ramifications of opt-in, opt-out, and related privacy matters. We could extend this also and carry on for the next question into data ownership, to explain what's done with their data, and if there's a monetary value associated with the data, who really should benefit from that in that chain of ownership. So, Dr. Meza?
Right. Well, I already alluded to, what's happening at least in the physician realm, is that whenever anything electronic comes in, the physician usually looks at the device or the electronic medical record, and they always say, this was never developed by a physician. Did they even talk to a physician? Who developed this? You know, and I'm not going to touch this. It's wasting my time. It's slowing me down. And it does. It's been, but we've talked about what the benefits of all this this entails as far as, you know, continuity of care, patient-centeredness, them owning the record. There's a huge benefit to that. And I've had to talk to my whole medical staff and sell them on the idea of that benefit. We're in a community that doesn't have HIEs, that doesn't have this continuity, that is very segmented in its data. So when do we take the time? And in a hospital setting, it's usually the front office staff that hands you the paper and says, this is about your, this is HIPAA information. They explain it, but the patient really hasn't really. Well, we have to think about where they are in in a certain communities where they are in this health information exchange. Some don't have it at all. And some are very sophisticated in markets where this is happening all the time, and the consumer or the patient or whatever you want to call them now is very sophisticated, and they carry their own information. In other places, they're used to the doctor not knowing what the other doctor did, or you know, you should have talked to them. That's sort of the norm. So in our community currently, HIPAA can be explained, it's most of the time in hospitals, explained by the staff at the front office, or it's explained by the front office staff in the clinic. The physician, though, I guess the point is that the physician should understand, and the physician is the one who should advocate and speak in terms of trust, like you talked about earlier. I completely agree with this, because it's that relationship. First, we're trying to sell them on the idea of continuity of care and the importance and how they're going to benefit from having their information exchanged from one to the other. But then we also, just like we talk about medications, there's all the good stuff, and then there's all the side effects: nausea, coughing, diarrhea, chills, aches that you see on the commercials. The side effects is the protection of their information. So talking about that with them and taking that opportunity to truly understand, and I don't know how many physicians really truly understand that. Some of them in busy practices are just trying to get their practices going and surviving with the amount of change that's happening in healthcare reform. So, and even in the hospital setting, some of the doctors are just trying to adopt to the electronic medical record system. In some states, like in my state in Texas, actually the governor passed in June of last year passed a law that's actually going to take in place in September that has stronger enforcement regarding training, regarding the protection, the expansion of who is protected. This actually came from a lot of advocacy groups really concerned about what happens to their information. So bottom line, one, a physician's going to always think that this slows them down, but it's our obligation to our patients to take that time and to understand ourselves what this means, and also be an advocate for our patients and help to I guess sculpt developing systems that are happening in a lot of different communities at different paces throughout the country.
Great, thank you very much. There's only about 5 minutes left, so I wanted to leave some time for questions from the audience. Does anyone have any questions for the panel? First to the mic wins. How about that?
Race to the mic. It's so early in the morning. Hi. How are you this morning? I have a couple of questions. As you went across, my question meter went And in what I do, I run across a lot of things related to what you talked about. Not so much the patients, but some of the things that you just mentioned. We, the organization I represent, sometimes don't understand why something happens. I'll give you something very basic. When you talked about the laptops, we have never understood why, other than, you know, and people say it costs money, but we go, it doesn't cost very much money. Why a physician would have a laptop that's not encrypted, regardless of regulations, just regardless of regulations. I'm thinking about being sued, you know, but we see this all the time. I've worked incidents where the laptop, it's gone. And how many records were, oh God, you never know. And at first it takes a while, it takes a long time for them. Nobody knows what's on their hard drive, they forget. Okay, so I'm asking the person who brought it up, lucky you. Why do physicians have portable devices when they know the stuff on there is sensitive and they still don't encrypt them? It only takes buying commercial software and running it once. Then well, actually, it is that easy. We hear that a lot. I've heard that from, well, that was one of the reasons somebody said, oh, I think it'll screw up my computer. And they told the technical person not to do it. And the technical person listened to the doctor. And then the machine walked, and then it was like Washington Post time. So that's one thing I wanted to bring up, is that from our perspective, this is a very big deal. And in fact, when we do audits, one of the first things we say to the people is, we provide a method for you to send us data that's securely encrypted. If you don't use it, we'll put it in our audit report that you send us data unencrypted. Well, it happens all the time. People are always mailing us PHI. Happens all the time. We have no idea why. I'll go, and so, any comments, really? Seriously, I seldom get so many doctors in one place at one time that I can just ask.
In regards to hard drive encryption, so
Sure.
I'll just jump in. Number one, I think we've looked at it and finally, as an enterprise, have carried that out. But for years, and not too long ago, it really wasn't that easy, and it really slowed performance down, and that's a hot topic for the providers. But number two is, I think, and it was brought up earlier, I don't think data should reside on the laptop anymore, right? I think
Sure.
the access and the size of the pipes to sort of use data elsewhere and keep it elsewhere is readily available. So I think that whole model probably just needs to go away and let data be somewhere else that isn't
that
encrypted.
That may be a difference between you and a smaller provider. DoD has big pipes.
No. So I'll just say, you look at all the different vendors now that are web-based tools.
Sure.
That I think, and I'm not saying in a remote area, but certainly in a DC area, you could support that.
This may be another area where providers and vendors can get together, and vendors can use as an opportunity to help educate providers. The collaboration between the vendor community and the provider community is essential, and vendors are in a unique position to make it clear that encryption is possible, and that and make sure that the software that is employed does lend itself to being encrypted, or at least the information lends itself to being encrypted. I mean, you're right, there are a wide variety of encryption softwares, but again, it does require some familiarity with it.
I agree that more recently, however, full disk encryption is an easy thing. It doesn't cost a lot. It doesn't affect performance. And I want to, because this is directly related and it's been mentioned, before we go too far down this idea that the cloud is the answer, I think that concept is really predicated on a lot of pieces that aren't in place and that have been articulated by the likes of Ross Anderson and others over the last day. That the fact of the matter is that the cloud certainly has potential, but we're not there yet, and we shouldn't continue to put the cart before the horse when it comes to applying the HIT. We need to demonstrate efficacy and safety before we move ahead. The DoD actually is an exceptional example of an organization that does a very good job of managing its data, moving ahead incrementally, thoughtfully, and they have some inherent advantages dealing with a single-payer system, etc. So I agree with you. I think full disk encryption, we shouldn't throw that out. It is viable and should be used.
Okay. I have more, but I'm going to defer so that other people have a chance.
Let's change sides of the room, please.
Thank you. Kathleen Frawley. First, Deborah, thank you for putting this together. It's been a great discussion. I just want to bring out, we need to stay focused on the patient. I started working in a hospital as a clerk in a medical records department in April 1968. The first day on the job was trained about the importance of medical records, making sure no doctor came in, grabbed them, ran out. And as a director of medical records in many hospitals for many years that were open 24/7, I could count maybe on one hand the number of times I was called by clerical staff I fast forward to a conversation with Arthur Ashe in 1992 when he talked about being treated at New York Hospital and he knew his medical record, how many volumes he had. He estimated it was about 17 inches. And the trust that he had in the healthcare delivery system. And the fact that he never worried about his HIV status being disclosed till the infamous day he gets a phone call from a reporter and then makes the decision to go forward with a disclosure. And then I think about all the work that we did in Washington on the National Committee on Vital and Health Statistics, making recommendations to the Secretary, and many of them were not accepted. We recommended that data be encrypted when it was at rest and not go through the pipeline at all, not accepted. That there should be a ceiling. We landed up with a floor. I've had aging parents in my own experiences in the healthcare delivery system recently. There's no clerical staff who can explain a notice of privacy practices. I've heard here the government wants you to sign this. I mean, I've sat in doctors' waiting rooms rolling around on the floor with some of these discussions. I now chair an HIT program. I've been in the field for 44 years. It is so complicated to understand primary uses of health data, secondary uses, and how information flows. And I've been in the field for 44 years. And as a medical records clerk, I've been a hospital administrator, an attorney, and now an educator. And I find it complicated. I'm thinking, how can we expect any consumer to understand what their rights are? And I will argue to my grave, the patient owns the information, and the dialogue should always be centered on the patient, and we need to keep that front and centered. And that's my comment. Thank you.
Thank you. That's great. And I want you to know, in light of my comments, I'm very much pro health information technology. Definitely not a Luddite. I embrace it tremendously. That said, I think that one of the best analogies, and that was a great question, for where we're going that I've come up with, and probably isn't a very good one, is collateralized debt obligations. Remember these financial instruments that were supposed to be so wonderful? They were supposed to be effective and low risk, very complicated, brought the world's economy to its knees, 2007, 2008. And in retrospect, we find that they were, in fact, very complicated. We had to hire the people who created them to try to unravel them, and even they said they didn't understand them. They turned out not to be efficacious. They turned out to be very high risk. And we're doing the exact same thing again. How short our memory is. We seem to have not learned a lesson. And we're moving ahead, full speed ahead, particularly post-high-tech 2009. And we're making tremendous mistakes. We're complicating the system. We're undermining privacy. We're undermining patient care and safety.
Great, thanks. Next question.
Hi. I see all seven of you physicians on the podium here. And my question to you all is, why are we putting up with EHRs at all? In the sense of the physician-patient relationship. All of you individually have said the same thing that the last comment was about, that this is about the physician-patient relationship. Ross yesterday made a very good case for access control to data in scalable networks being tied to the patient. The idea that the data can move to the cloud or to the behind the barbed wire. Your idea about being out of control with respect to the interface that you're using in documenting your interaction with that patient, the fact that you are tied to a 5-year upgrade cycle that is out of your control in many cases. And so what is it about looking for the solutions to the issues of the healthcare today that causes us to look under this lamppost called the EHR?
I think you have to look at healthcare in a broader sense. There is no technology that we have ever implemented in healthcare, none, that has been perfect, that has worked perfectly from day one and hasn't needed improvement as it developed. And it, like everything else in healthcare, this is a sort of a cost-benefit analysis, right? There's no drug that's perfect. There's no drug that has no side effects and whatever. So what we're trying to do, and I think it's appropriate to do, is to focus the light on the problems so that we can fix them, right? I mean, that's not the same as saying we're just going to throw it out. Now, and if you let me just finish. If you come back to what I said at the beginning, and I really believe this. This is about improving the quality of care for our patients, and I believe that one of the greatest failings that we have in quality of care is availability of information and the ability to collaborate around a patient. As was mentioned earlier, anybody who's had an elderly parent or elderly relative or something that they've taken care of or they've helped go to the doctor has been faced with the situation about one doctor not knowing what the other doctor did, not knowing what medications the person's on because they're a little bit too old or whatever to remember, all of those kinds of issues. These are solvable problems. Do they create other issues? Of course they do. I'm not minimizing the problem. I'm saying that we have to keep as was mentioned before, the patient has to be the focus here.
Yes.
And the focus is on how do we improve care for the patient. And this is one tool. It's not the only tool. It's definitely not a perfect tool, but it's a tool that we can use to do that. And I think that, the VA is a great example of documented improvement in care because of medical information being available. Now, I think Dr. Weiner would admit that the VA system isn't perfect and that there are issues with it and there are questions about how it's run, et cetera, et cetera. But I think there's great literature about how patient care in the VA has dramatically improved over the last X number of years because of the availability of this technology.
The epidemiology of patients are also changing. We have to keep in mind that we've got an aging baby boom population where people are going to be on multiple medications, and the issue of diagnosis becomes very complex, and people are living longer, and there are a host of other issues associated with it. EHR and HIT can assist us, and in electronic health records and the broader umbrella of health information technology, we can be able to facilitate prevention, we can facilitate patient self-monitoring, we can facilitate a lot of things. And I think the beauty of this kind of discourse is that we do look at the underbelly of the issue, but we don't abandon the issue because, indeed, so it's as the point was, this is not about being a Luddite. This is about understanding the periphery of the issues and making sure that we protect patient quality and patient care. So we don't want drug interactions when people are on multiple medications. By the time you're 80, you're on 5 to 8 medications. And we were able to use this data. We do surveys right now. For instance, the National Survey on Drug Use and Health interviews 67,000 people just to figure out what's going on with them. You're going to have records on 300 million people. We'll be able to detect diseases as they begin to surface. We'll be able to figure out how we can facilitate clinician education so that we can better prepare patients and practitioners for the care. It's hard to collect that kind of information without electronic health records and HIE. So the promise is great, the problems are great, but collectively I think we can address them both, working with the vendor community, provider community, and consumers.
Okay, thank you very much. I think we're about out of time.
I thought that was a great summary.
Sorry. I just want to close with one comment. We're in the first steps. This is early on in the EHR process. We've got some huge challenges in front of us. Genetic error is going to change everything for us, potentially. Privacy is a huge issue. I'll give you an example, a somewhat chilling example. When the American College of Medical Genetics goes in and analyzes communities and looks at their DNA, they find about a 5 to 10% incidence of unsuspected non-paternity. So in Texas, we're going to have to ban guns before we run those kind of surveys, because the HIE is going to show who's really connected to who, potentially, unless we figure out a way to make it private and secure. So we have some really interesting challenges ahead of us. So it's very early on in the whole world of HIT. But I think we're out of time. Okay, we're going to have to wrap up now, but thank you very much.
Well,
Thank you, panel members.
I can see we're going to be doing this panel again. Everybody really wants to hear from the physician.